Welcome to another deep dive. This time, we're going to decode the medical coding behind COVID-19.
Yes, we'll be looking at how these guidelines, sort of like a roadmap, helped medical professionals record all of the details accurately.
And we've made it easy for you, too. You can find a link to the Absolute Medical Coding Institute's MCG manual in the description.
Absolutely. This manual is a great resource if you want to dive even deeper on your own.
So let's think back to the early days of the pandemic, when things were so uncertain. I remember hearing stories uh, about testing shortages and doctors having to rely more on their own judgment.
Oh, yeah, for sure. Those early days were tough.
So how did these guidelines actually address that? Especially when it came to actually confirming a COVID case.
Well, one of the key things these guidelines did was they made it really clear, what criteria had to be met for a confirmed COVID diagnosis.
Okay.
It wasn't just about having a positive test result, although of course that was the gold standard.
Right. So what else could be used to actually confirm a diagnosis then?
Well, believe it or not, a doctor's documentation alone could actually be enough.
Really?
Yeah. If a physician, based on their clinical evaluation, determined that a patient had COVID-19, all they had to do was document that. And that would be considered a confirmed case, even without a positive test.
Wow, that's interesting. So a doctor's expertise and judgment really carried a lot of weight, especially back when those tests were so hard to come by.
Oh, absolutely. It was crucial in those early days when testing just wasn't widely available.
Yeah, it makes sense. I mean, it's kind of like a detective using clues to solve a case, even when they're missing some pieces of evidence.
Exactly. That's a great analogy.
So this really helped with early tracking and reporting of cases then, even when testing wasn't readily available.
Yes, definitely. It helped give a more complete picture of how the pandemic was actually spreading.
That makes sense.
Yeah.
So once a case was confirmed then, there was a specific code that, kind of took center stage, right?
You got it. That was the famous UO 7.1.
UO 7.1.
The ICD-10-CM code, specifically for a confirmed COVID-19 diagnosis.
Okay.
This code, it practically became synonymous with the pandemic itself.
Oh, yeah, definitely. I remember hearing it everywhere.
Yeah, every time it was entered, it contributed to this massive data set that helped track, how the virus was spreading, how severe it was, and ultimately how to respond to it.
Wow. So it really became a digital fingerprint of the pandemic then. It was everywhere.
It really was. And it was so important for researchers, public health officials, for everyone who was trying to get a grasp on what we were dealing with.
And not just for tracking individual cases either, right?
Yeah.
I mean, using UO 7.1 also had a big impact on things like resource allocation.
Right. Like figuring out where to send ventilators and other important medical equipment.
Exactly. It's amazing how much impact just one single code could have.
It really is. And it reminds us that behind the scenes, these codes are doing a lot more than just documenting diagnoses. They're actually shaping how we respond to health crises, right? They're like a vital part of the infrastructure that helps us understand and manage outbreaks.
Exactly. Okay, so we've got our confirmed cases all coded with UO 7.1. But it wasn't always just about that one code, was it?
No, not at all.
Because I imagine things got a little more complicated when you had to take into account all those different symptoms and complications that came with COVID, right?
Oh, for sure. There was a whole system for sequencing these codes to make sure they reflected the full picture of a patient's condition.
Okay, so break it down for me. What exactly do we mean by sequencing codes?
Okay, so imagine this. When a patient came in and COVID-19 was the main reason, the primary reason for their visit,
Right.
and UO 7.1, that took the lead.
Right.
It would be listed first, and then that would be followed by the codes for any related symptoms or conditions.
So, for example, if someone came in with, let's say, a confirmed case of COVID, and they were also experiencing pneumonia at the same time, then you would list UO 7.1 first.
Exactly.
All
You
right.
put UO 7.1 before the code for pneumonia because that shows that COVID-19, that was the driving force behind their illness.
Got it. So it's about establishing a hierarchy, right?
Yes,
Showing the primary reason for the visit and then any other associated conditions.
precisely.
I like to think of it like those choose your own adventure books.
Mm-hmm.
Each code leads you down a different path and paints a more detailed picture of the patient's overall health. But I'm guessing it wasn't always that straightforward. Were there ever situations where UO 7.1 wouldn't be listed first.
Oh, yeah, definitely. There were definitely some exceptions to the rule.
Okay.
In cases where, let's say, sepsis was involved or pregnancy complications or issues with newborns, those all had specific guidelines for sequencing codes that took precedence over the general COVID-19 guidelines.
So it really wasn't a one-size-fits-all approach then.
Yep.
Coders had to, really understand the specifics of each case to make sure they were applying the right codes.
Absolutely.
That's a lot of responsibility.
It is. Medical coders played such a crucial role in making sure that the COVID-19 data was accurate and complete, because ultimately that information is what informed public health decisions and medical research.
It's like they were the unsung heroes of the pandemic then,
Yeah.
working behind the scenes to make sense of all that data.
Totally agree with you there. They were essential in helping us understand and respond to the pandemic.
So speaking of understanding, I want to talk about how these guidelines captured the fact that COVID-19, it wasn't just a respiratory illness.
Right.
It affected, it affected other organs and other systems, and it can show up in so many different ways. So how did the guidelines handle that?
That's where things get even more interesting. We saw codes for a whole range of conditions, both respiratory and non-respiratory, that were all linked to COVID-19.
Okay, give me some specifics. What kinds of things are we talking about here?
Well, we're talking about everything from, acute bronchitis to pneumonia to ARDS, which was, that was one of the most severe respiratory complications.
Right.
But then we also saw codes for things like heart complications, neurological issues, and even gastrointestinal problems that were later linked to the virus.
Wow, it's like COVID was a chameleon. It was changing its appearance and affecting people in all these different ways.
Exactly. And these guidelines, they helped capture all that complexity. They gave us a way to code for the full impact of COVID-19, not just what it did to the respiratory system.
That's amazing. And it almost seems like these codes were able to evolve and adapt as we learned more about the virus. Like they were constantly playing catch up.
You could say that. The guidelines were constantly being refined and updated as we learn more.
Okay, so now, I know you mentioned earlier some special circumstances and nuances in coding for COVID-19. Are you ready to dive into those?
Oh, absolutely. Those are some of the most fascinating cases because that's where the guidelines really had to flex their muscles to capture the full picture.
All right, but before we do, let's take a quick pause here to let all of this sink in for our listeners.
Yeah.
Because it's easy to get lost in all the technical details, but it's important to remember that each one of these codes, it represents a real person,
That's so true.
a real life that's been impacted by COVID-19.
Each one tells a story. And together they paint a really powerful picture of the human cost of this pandemic.
Exactly. And they also provide us with valuable insights that can help us better prepare for future health challenges.
Absolutely. They're not just about the past. They're about shaping the future.
All right. So are you ready to move on to the next stage of our deep dives and explore some of those special circumstances?
Absolutely. I'm really eager to see what other insights we can get from these guidelines.
Me too. We'll be back right after a quick message.
Welcome back. Now let's dive into some of those tricky situations where the guidelines really had to adapt. Remember how we talked about, distinguishing between suspected and confirmed cases? Well, that line wasn't always so clear.
Right. Especially early on when testing was so limited, there was a lot of gray area.
Exactly. So let's say, someone comes into the hospital and they've got symptoms that could be COVID, like a fever, cough, shortness of breath, the whole 9 yards. But they haven't gotten a positive test result yet.
Okay.
How would you code that?
Well, it wouldn't be a confirmed case yet, right?
Right.
So you couldn't use US 7.1.
Exactly. So in those cases, coders had to rely on coding for the specific symptoms that were actually being presented. So you'd have a code for the cough, a code for shortness of breath, a code for fever. Each one's kind of telling part of the story.
Like putting together a puzzle, right?
Yeah.
Using all the clues you have to try and get a clear picture of what's going on.
Exactly. And then if there was a known or suspected exposure to COVID, you'd add the code Z20.822 to the mix.
Oh, okay.
To show that potential exposure.
Gotcha. So even without a confirmed diagnosis then, these codes were still helpful for tracking and monitoring potential cases, which I imagine was was really helpful for public health surveillance.
Oh, absolutely. It helped identify, clusters of symptoms that could point to an outbreak even before those cases were officially confirmed.
Wow, so they were kind of like early warning signals then,
Yeah, you could say that.
alerting public health officials to potential hotspots. Now, what about those cases where someone tested positive for COVID, but they didn't have any symptoms?
That's another really good example of where those guidelines really had to think outside the box.
Yeah.
You're talking about asymptomatic cases, which were a huge part of the whole COVID story.
Right. Asymptomatic spread was a big challenge because it made it so much harder to contain the virus.
Exactly. And the guidelines recognized how important it was to capture these cases, even though they weren't showing the typical symptoms. So even people who were completely asymptomatic but tested positive for COVID, they still received the UO 7.1 kind.
Wow, the same one used for the symptomatic cases.
Yep, the same one.
So a positive test was really the deciding factor then, regardless of how the person was actually feeling.
Yeah, because from a public health perspective, asymptomatic people were still considered infectious. They could still spread the virus. Tracking them was just as important as tracking those who were showing symptoms.
Makes sense. It's like saying, hey, don't be fooled just because this person doesn't look sick. They're still a potential spreader.
Exactly. And using the same code for both symptomatic and asymptomatic cases, it helped us get a more accurate understanding of how prevalent the virus really was and how it was actually spreading.
It's amazing how much of a difference just the simple code can make in how we understand a disease.
Yeah, it really is. And speaking of impact, let's shift gears for a minute and talk about the long-term consequences of COVID.
Okay.
Because we know that for a lot of people, the effects of the virus, they lingered long after that initial infection was gone. So how did the guidelines take that into account?
You're talking about long COVID,
Yeah.
right? Where people experience these lingering symptoms weeks or even months after they've recovered from the initial phase of the illness.
Exactly. And as we started to, understand how widespread and complex long COVID actually was, the guidelines had to change to reflect this new reality.
So how did we do that?
Well, they introduced a brand new code specifically for post-COVID conditions, UO 9.9.
Okay.
And this code, it was a real game changer because it finally acknowledged that the effects of COVID could last, long after the initial infection.
So if someone came in with, let's say, fatigue or brain fog months after they recovered from COVID, you would use UO 9.9 to show that those symptoms were most likely a result of their previous infection.
Exactly. It was a way to connect those long-term symptoms back to that original COVID diagnosis, even if the virus itself was no longer in their body.
And that's really important because without that code, those long-term effects, they could easily be mistaken for something else, right?
Right.
And the true scope of long COVID, it could have been completely underestimated.
Exactly. The introduction of UO 9.9, it was a big step toward really recognizing and validating what people with long COVID were going through.
It's like saying, we see you, we hear you, and we're taking your symptoms seriously.
Exactly. And using UO 9.9 also helps track how many people were experiencing long COVID, identify, common patterns, and ultimately it helped guide research and treatment efforts.
It's just amazing how much these codes helped shape not only, how we understand the past, but also how we approach the future of COVID care.
I agree. It's really a testament to the power of data and how important it is to have a system that can, adapt to new challenges and keep up with our evolving knowledge.
Speaking of new challenges, let's talk about another aspect of COVID-19 that required, some creative coding. Vaccination.
Yeah, vaccination. That was a huge turning point, and the guidelines had to find a way to incorporate vaccination status into the coding system.
So how did they do that? Were there specific codes for people who were vaccinated versus those who weren't?
Absolutely. We had Z28.301, which was used for anyone who was unvaccinated against COVID, and then Z28.311, which meant that someone was partially vaccinated. And those codes were really important for tracking vaccination rates and understanding the level of immunity in different communities.
It's crazy how something as simple as a code could contribute so much to those public health efforts.
It really is. These codes provided the data that was needed to inform vaccination campaigns, track how effective the vaccines were, and monitor any breakthrough infections.
It's like all those little codes were little pieces of a giant puzzle, helping us see the bigger picture of the pandemic and how we were responding to it.
That's a great way to put it. Each code, it contributed to a larger tapestry of knowledge.
Okay, so we've covered a lot here, from suspected cases to long COVID to vaccination status. It's incredible how these coding guidelines were able to capture, well, so many different facets of this pandemic experience.
It really speaks to how adaptable and resourceful the medical coding community is. They really stepped up to the plate to document this unprecedented health crisis.
Now, I know you mentioned earlier that there were some even more nuanced scenarios that came up, cases where coders really had to put their knowledge and expertise to the test.
Oh, yeah.
So are you ready to dive into those?
Absolutely. Those are some of the most interesting cases because they really show how those guidelines had to be interpreted and applied in all these creative ways.
Okay, great. We'll get to those right after a quick break. Stay with us.
We're back and ready to tackle some of those really nuanced COVID coding scenarios. The ones that really made coders think outside the box.
Oh, yeah. There were definitely a few head scratchers that forced us to really consider all the subtle details. Like, let's say someone had recovered from COVID, but then they come back for a follow-up visit.
Yeah.
How would you code that?
Well, it wouldn't be a current infection anymore, but you'd still want to make a note of their past history with the virus, right?
Exactly. That's where the code Z86.16 came in.
Okay.
That's the code for a personal history of COVID-19.
Gotcha.
So even if someone's fully recovered, and they don't have any more symptoms, that code, Z86.16, it's still added to their medical record to show that they had the virus at some point.
It's like a little footnote in their health history.
Exactly. And it was important for a few reasons. For one, it helped us track the long-term effects of COVID, even for those who seem to have made a full recovery.
Okay.
And let researchers study, potential long-term effects that might not have been obvious right away.
So even if someone was feeling fine at that follow-up visit, adding that code, Z86.16, it made sure that their past COVID infection wasn't just forgotten.
Right. It kept that information in their medical record, which could be really important down the road for making diagnoses and treatment decisions.
It really shows how much these codes were kind of thinking ahead. They recognized that COVID could have a lasting impact, even for those who didn't seem to have a tough time with the initial infection.
Absolutely. And second, Z86.16 was important for billing too.
Oh, right.
Sometimes insurance companies needed proof of a past COVID infection to cover certain tests or treatments, even if those weren't directly related to the virus.
Yeah, that makes sense. So Z86.16, it wasn't just about tracking the virus, it was also about navigating the whole healthcare system.
Exactly. It had a foot in both worlds, clinical and administrative. It's amazing how much those seemingly simple codes could impact things.
They really could. And speaking of impact, let's talk about another scenario that needed some careful coding. What about those times when someone had an antibody test, but it wasn't for, confirming a current or past infection?
You mean like when antibody tests were being used for research studies?
Exactly.
Or to figure out, what the immunity levels were in different populations.
Exactly. And in those situations, there was a special code, 01.84.
Okay.
Which was used to distinguish those tests from, the ones used for actually diagnosing people.
Yeah.
And that was really important when it came to analyzing and interpreting all that data.
Right, so you're not mixing apples and oranges.
Exactly. You want to make sure you're comparing the right things and having separate codes for all those different types of antibody tests. Well, it helped to ensure that the data was accurate.
Okay, that makes a lot of sense. There's one more specific situation that I wanted to ask you about, and it's one that I remember being pretty complex. What about MISC?
MISC?
Yeah, multi-system inflammatory syndrome in children.
Ah, right.
It was rare, but it was a serious complication linked to COVID. And I imagine coding for it must have been really tricky.
Yeah, you're right. MISC kind of threw us a curveball, and the guidelines, they had to adapt pretty quickly to capture this new and really complicated condition.
So how did they do that?
Well, they created a specific code for MISC itself, M35.81.
Okay.
But how it was actually used, well, that depended on when it happened and how it was connected to COVID.
Okay, can you walk me through like the different scenarios?
Sure. So if MIS-C happened at the same time as a current COVID infection, you'd use both UO7.1 and M35.81 together.
Okay.
That showed that both conditions were happening at the same time. But if MIS-C developed, after a previous COVID infection, then you'd use M35.81 with U09.9, the post-COVID code.
So it's like a branching tree of codes. Each path kind of leads to a different way of understanding how MIS-C showed up and how it related to COVID.
Exactly. And then if someone developed MIS-C, but there was no record of them having COVID, then you would use M35.81 along with Z20.822, the code for potential exposure.
It's amazing how much those codes were able to show about MIS-C, recognizing that its connection to COVID wasn't always so straightforward.
It really shows how those guidelines were designed to be flexible, to be adaptable, to capture the full spectrum of this incredibly complex disease.
Well, I think we've covered a lot of ground here today in this deep dive into the world of COVID-19 medical coding. It's been really eye-opening to see how these codes, these combinations of letters and numbers, have played such a critical role in documenting, understanding, and responding to this global pandemic.
I couldn't agree more. It's been fascinating to explore these guidelines, and to see how they helped us navigate this truly unprecedented health crisis.
And it really highlights the expertise and dedication of all those medical coders out there. They often work behind the scenes, but they have such a vital role in shaping healthcare data and informing public health decisions.
They really do. They're the unsung heroes of the pandemic, making sure our understanding of COVID is as accurate and complete as it can be.
And on that note, we're going to wrap up this deep dive. But as we all move forward, I want to encourage you to keep thinking about the long-term impact of COVID-19 and how our understanding of this complex disease is going to continue to evolve. Thanks for joining us.
Until next time.